In the time between now and morning tea, I'd like to engage you in considering what is this system of care that we're wanting to build. What is a system of care? What is this system of care that we want to build for eating disorders? We will look at what is the system of care, how do we build a system of care, and what we will do today to build a system of care. So, what is this system of care as a concept? So, the intention of the system of care concept is to be a guide for service systems and service delivery to improve the lives of people who are experiencing eating disorders and their families and supports. So what is it? It's an organisational framework for systems building and reform, a guide to local and national solutions. What isn't it? It's not a model for replication. It's not static across time or context. It's not a definition of which agencies should provide which services. The concept of the system of care was first developed and published in the 1980s in the US in relation to children and adolescents with mental health challenges and their families. The concept was the result of collaboration between multiple and diverse stakeholders there. And 35 years later, that concept of the system of care is still widely accepted and used and has been broadly influential in national policy and in developing service systems. So systems of care are dynamic. They are not static. It's apparent when you think about it. They must change over time as a result of new policies, organisational structures, service delivery approaches and research. The content of the system of care will be changing. The concept itself, though, is something that we can hold as an image of what we are working towards. That's what it is. Okay. So the definition of a system of care, first and foremost, a system of care is, of course, a response to a person who's at risk of or experiencing an eating disorder and their families and supports. That's what it's for. What is it? It's a coordinated network of services. I can say that quickly. It's much harder to achieve than say. A coordinated network of services and supports that's able to deliver the right treatment at the right time and respond flexibly to changes in the person's needs over time, regardless, and this is something you can say quickly, but is much harder to achieve, of the person's geographic location, of their age, their economic circumstances or cultural group. You might be familiar with the concept of the stepped care system. Oh, hang on. Okay, we'll go here. So, just before we go there, is the stepped care system a concept that sort of, people are hearing, people understand that it relates to the idea of the system of care, and it's slightly more particular as well. So today I'm going to sort of combine them together and apply them to our situation in eating disorders. The concept of the stepped care system is an important one, though, because it is central to the Australian government's mental health reform agenda. For example, from 2016, stepped care approaches have provided the basis for primary health networks planning. The distinctive thing about stepped care versus system of care is that stepped care approaches involve the delivery of evidence-based treatments that increase or decrease according to, in intensity, according to the individual person's needs. And I think if you think about it, you can see straight away that that's very relevant to the experience and the needs of someone with an eating disorder, that there's that changing need for a responsive system that can do that. So it's useful for us in that sense. In the stepped care system too, there's an emphasis on early intervention at the level of guided self-help and brief interventions. The provision of a stepped continuum of care for people with eating disorders really has been supported by expert consensus in our field, as well as the ideal approach. And the continuum needs to include a full spectrum of the levels of intensity, with a skilled assessment of need and coordinated transitions between services. So the national framework that Philippa mentioned before and the Australian clinical guidelines for eating disorders identify that a stepped set of treatment options should be available for people with eating disorders, including outpatient, community-based, intensive community-based, day program and inpatient treatment. That spectrum doesn't include prevention, but actually prevention and community communication is also very much part of that spectrum here. So when I'm talking about it today, I'm combining that broad sense of that system of care in a general sense with this sense of a step care system that really is very much part of the Australian political and practical health system. So what's been your experience of the system of care for people with eating disorders? What shows up for you when I say those words, system of care? Do you glaze over? It's possible, you know, or are you thinking of particular entry points or experiences that you have? Because I suppose my guess would be that almost everyone in this room has had significant experiences of parts of the system of care. I mean, perhaps you know the system of care for eating disorders from the inside as a person with lived experience or as a support. Perhaps you're a clinician and you navigate the system mainly around your own practice. Perhaps you're a service or systems leader and you spend a lot of time thinking about the service system. There are weird people like me who are in that situation. But we see the system from where we know, yeah? So we all see the system from the parts of it that we've engaged with. And it's my impression that those involved with the system of care for eating disorders, whether via lived experience, professional commitment, or a combination of these, are deeply involved in the parts of the system they touch. I see an extraordinary amount of human care and commitment and focus in the ways that we encounter this system. And I think that's part of what it is to be involved in this area because of the compelling nature and the suffering that's involved in this and the will, I suppose, we have to move people to recovery and to because it matters, because there's so much at stake, is what I mean. So I'd like to have a bit of a whimsical think with you for a minute now about how we see and understand the system of care. So what's this? Now we can go. It's a part of something, right? Just put up your hand when you see, if you give me an idea if you start to see what it is. Yes? Okay, a little bit longer. Yes. Okay? Can everyone see what it is? It's a platypus, right? It is, it's a platypus. Yes, it's a platypus, seen by early European settlers in Australia. Our unique, shy platypus, who is sadly somewhat vulnerable now due to climate change and bushfires. You've probably heard that the early Europeans found it very hard to see a platypus. The parts didn't fit into a hole that they could recognise. One report, it appears to possess a threefold nature, that of a fish, a bird, and a quadruped, and it is related to nothing we have hitherto seen. Hitherto, that's a great word, don't you think? Wondering if I can work it in somewhere else. It's a little like that. Is it a little like that in relation to the system of care for us? Could it be that partly because we are so involved in the parts of the system of care that have touched us and that we know well, it's kind of hard to carry an image of the whole and what the whole needs to be? Our experience, knowledge and expertise from the parts of the system we know well are obviously absolutely crucial. This is what the building blocks are for a workable, compassionate system. But might it also be useful to carry with us an image of the whole system of care working well? Something we can focus our plans towards and test our outcomes against. We can sense the Europeans' pain again in the name they gave the platypus. Ornithorhyncus Paradoxus, right? Right. Another report. Then comes a quadruped as big as a large cat, with the eyes, colour and skin of a mole, and the bill and web feet of a duck, puzzling Dr. Shaw and rendering the latter half of his life miserable from his utter inability to determine whether it was a bird or a beast. Poor Dr. Shaw. So one definition of a paradox is a personal thing that combines contradictory features or qualities. I'm wondering if the field of eating disorders also shares this feature with the platypus, because eating disorders present challenges to the traditional organisation of treatment for mental illnesses and physical illnesses. With eating disorders, it is physical and mental health services. It's private and public services. It's prevention and treatment. It's health and community services. And we need to work with multidisciplinary professional disciplines. So I'm thinking, let's not spend the latter half of our lives confounded by the different categories like Dr. Shaw. In a functioning eating disorder system, these different aspects of the infrastructure just have to work together. So what I'm saying is it's not useful to be completely focused on this is a medical problem, or to be focused completely this is a mental health problem. We actually have to find that flexibility to join those things together and to educate people to be able to do that. And that will affect then the kinds of ways we can organise systems to suit people better, to respond to their needs better. So here's another picture from Auntie Joy's book. This is a Dule Warong, pictured here in harmonious ecological relationship with everything that surrounds it, integration and collaboration. What would it be like if the system of care for eating disorders was well integrated with other health and social systems? But is a coherent and integrated system of care even possible? I don't know what you're thinking. The British scientific establishment didn't believe the platypus was possible. They thought it was a hoax, until specimens were sent to England and duly examined. Yet, here it is. It's true, isn't it, that a coordinated network of services and supports that's able to deliver the right treatment at the right time for anyone in Australia doesn't exist, does it? It doesn't exist now in its entirety. There are so many gaps and disconnections. But let's return to the intention of the system of care concept, which is to provide a guide and a reference point to service systems and service delivery in order to improve our response to people experiencing the painful and difficult life circumstance of an eating disorder. What's the ideal system of care in your mind, if you imagine it? Do you imagine it working through the healthcare system that we already have, for example, through primary care, GPs, community health services, headspaces, and the adult and child public health networks? Or do you imagine eating disorder care occurring in specialist services separate to the main system of care, public health care system? I think there's been a change in the last decade in respect of this. There's increasing recognition that eating disorders need to be core business within primary health care, that we won't achieve early intervention or better treatment outcomes earlier without GPs and community health services identifying, assessing and at times providing early treatment for eating disorders. There's also recognition that the eating disorder specific centres of clinical expertise, so the specialist centres, are critically important to provide treatment, but also to guide, support and provide consultation to the rest of the system. So that in order to develop a sustainable and effective eating disorder system at any level, whether it's in a region or nationally or in an organisation, we need to utilise the existing health system coordinated with specialist eating disorder clinics and elements. So one of the challenges for us, I think, is for the system of care to become more inclusive. It needs to become bigger and expand, but at the same time, it needs to be better integrated and better coordinated. So that's hard, right? Because if something's becoming bigger, it's harder to coordinate it. And it's also really important as it expands that we keep quality and excellent care within it. So it's challenging, I think. That's one of the things that faces us. Okay. So here's a couple of useful system of care concepts, so tools as we think about the system of care. The function of the system of care, what do we want from it? What does it have to do? You know, if I asked you, it has to do certain things, doesn't it, flexibly? Then it has to have an infrastructure. Where does these things happen and who does them? And it needs to have principles and standards. So how do we want to do these things? What guides the how, the values with which we do things? Another set of things to remember, because the system of care is huge, I understand that, a massive concept. There's a systems level, So there we're talking about policy, strategy, funding, organisational, regional, state, national levels. Then there's a program level at which service delivery occurs of all different kinds of programs. And then there's the practice level, and that's the level of relationship and interaction and the hands-on interactions and relationships that we need to have in order to make that work. And as you can imagine, they all interrelate with each other. I know that seems a little bit abstract, so let me tell you a story about Maddie. So Maddie is a girl from the country, and she developed a very intense case of anorexia nervosa. And her mum had her own quite serious health issues, and Dad had a huge workload on the farm. They worked with their CAM service, local CAM service, but her eating disorder just couldn't get contained within that. And so Maddie was bouncing in and out of the small local hospital to keep her alive, but things weren't moving on. And even having admissions to the special service in the major city still didn't shift the situation. So the hospital staff in the local hospital were really concerned and frustrated, of course, and there was sort of no progress and a sense of hopelessness of what is going to happen for her. So it was a dangerous stalemate. Isn't that a dangerous situation in terms of what's at stake for that young woman in her life at that time? So what happened was Maddie's parents and her CAMS team pulled together communication and conferencing with the medical and nursing leadership, so the directors of that local hospital. The hospital clarified its role and said what we can offer and what we can't offer, and they got a shared plan together involving the specialist outpatient service as a reference point as well and as an option. So the nursing staff got training in meal support, and the staff accessed consultation from the specialist service. So Maddie's ED got contained with the new plan because she had a structured and a predictable plan that uses the steps of care properly. And things improved for her and her family. She got onto the road of recovery, and her mum said, look, I can finally see some light at the end of this tunnel. That's what we're aiming towards here. That's what it's all about. That's the response that we're wanting to make. But can you also see the complexity of managing those different layers in order for it to be consistent and to create that response? Yeah? So that's like a bottom-up way of changing the system from the person level up. And of course, change can also happen top level down. So it can be that policies can change at government and at leadership level here that could change. For example, in that instance, it would be possible for policymakers to say, we think actually what we need to do is put more EFT into specialist services in the city so that they will have capacity to support local hospitals more and to be able to engage in these kinds of coordinated plans. So that would be a policy decision, and that would come down then to Maddie's family. Do you see what I mean? It can go both ways. Yeah. So what do we already know about the system of care for eating disorders in particularly? Quite a bit, actually. We've got quite a few ways that we picture it and we think about it. And what I'd like to do is just show you a series of pictures and ideas that we already have that kind of do that. And then me and Emily have made a bit of an integration at the end and had a go at sort of mashing up something that integrates them. But let's look at the kinds of ways you might be familiar with or you might not be familiar with about how we picture this idea. This is one's fairly familiar to a lot of people, yeah? So tiers and infrastructure, and this is a very traditional way of picturing the health system. So it's really good for picturing infrastructure, so what, and also for who, because it's got sort of fairly prescriptive ideas about who should be in the different spots in relation to it. And it works from the traditional way of seeing the medical system, which is tier 1, which is the big thing, and that's good. You see that is bigger, and then it goes right up to the acute services at the top. So it gives us information about infrastructure. The thing I, personally don't like about it is it sort of creates, for me, a bit of an impression that the most important part of eating disorder care is acute care, and I think that's problematic. Because eating disorder care needs to be flexible for the person all the way across the different options. So I'm going to show you one in the middle that sort of turns it on its side a little bit. Okay, next one though is different. So this is a different approach again. This one actually evolved from working out clinical competencies, what clinicians need to be able to offer. And of course, what clinicians need to be able to offer is also what we need in the system, if that makes sense. So these are the basic, it's like a broad brushstroke of the functions of the system. What do we need it to do? We need it to provide early identification. We need it to make an initial response to people, to show them where to go, to get the shared care and treatment that they need, and then recovery support. So it's broad brushstroke, but it gives us an image of what all the things that we kind of need. Something that isn't included there is prevention and community communication. And again, I think it's important to include that. Okay, so the next one, thank you to SEED for this, Victorian Centre of Excellence for Eating Disorders. They've tipped the thing on its side and made it more like steps here. So different information is involved in that. There's sort of the functions at the top, so it's telling us what needs to be done at the top, and then it tells us sort of, interestingly, which it's got having a bit of a go at which presentations of eating disorders actually fit into the different contexts as well. And then it's telling us where to do it too. So it's got a fair bit of information there. And interestingly, it's also looking community down that end and hospital up this end. So treatment intensity is lower down this end and treatment intensity is higher. So it fits very strongly, doesn't it, in with the step care system I was talking about before, because it's defining intensity and it's also saying how that intensity might play out with particular presentations. Another thing you can look at that too is that cost is lower down that end and cost is higher up this end. So that's another useful way of looking at it. Next. So another way that we look at the system of care isn't so much picturing it and figuring out its function and its infrastructure, which is what we've been talking about. It's also, as I said, about how we do it. Like, how do we want to be? How do we want those interactions to operate between people in the system of care? And principles and standards are very important in that. And this is something that the NEDC, as Philippa has said, has worked really in a very consistent way across a decade to gather information from a number of different areas and to bring it into principles of care that can guide us. So principles are fundamental qualities that serve as the foundation of a system. So I'm not going to read them all, but say, for example, person and family-centred care. Okay, so it's a big idea, right? Crucial with eating disorders, and increasingly crucial as the years go on, that the care is centred to the person and that families and supports are absolutely integral part of that. We know we need that, so that's an example. Another one is equity of access. That's a big principle, and we don't have equity of access at the moment. We don't have equity of access regionally and rurally. We don't have equity of access state-wise and territory-wise. We don't have equity of access in terms of money as well and finances. So, but these are the guiding kind of things that say, this is what we need to work towards, these principles. We also have implementation principles from the NEDC, which talk about what do we need in order to get these things to happen. What are the kind of guiding principles? So, for example, we need to have evidence-informed and evidence-generating processes. So we also need to have a skilled workforce. These are the things that we need to work towards, and they're all big. The other thing I just want to say about this is there has been a lot of work over the last couple of decades in bringing these principles into standards. And there are really important and useful standards and guidelines that are widely used as well. So the RANZIP standards are crucial, and there are other ways in which these are being brought down and made specific. So, for example, if you go to a hospital in Queensland, you're probably, and actually maybe across Australia, you're very likely to get a set of guidelines that were developed up in Queensland. And because they've brought the principles down into here's a protocol. So these things aren't only abstract sort of ideas, they've also been worked down into kind of usable, pro formas. Another example would be NEDC is working strongly at the moment with PHNs to work out how they can, get their services into place in guidelines and in sort of actual actions. So, yeah, they're not just abstract, but they do guide us. Yep. What about the system of care from the inside? I don't think it seems like this. I don't know. From hearing many people's accounts of their experiences within the system, I don't think that many people feel that when they start to experience an eating disorder or at risk of one, that they have an array of options, that they feel, that they can go flexibly from one to the other. I mean, imagine what that would be like if you did feel, look, I'm really held securely by this series of options so that if this happens, I sort of know I can go there, I think it's more like this. So here's a person, and they want someone to notice there's something wrong. Are they going to get that? Don't know. Would depend, wouldn't it? Yeah, it might take a long time. Here's another person. They want to go to the emergency department. How's that going to turn out? Emily first put a tick on that and I was like, no, we can't put a tick. Yeah. Here's another person. Clinicians who can help, okay? I put a tick because I think we're starting to get there, More intensive treatment. What's it going to cost? How am I going to manage that, really? And hospital support. In this case, no, but sometimes yes. Yeah, so I think that it... I completely lost my place. So it feels more chancy and chaotic and one door at a time, I think, from the inside, if I'm understanding what I hear from people with lived experience. We'll be hearing from people with lived experience later this morning about their experience of treatment pathways. So it'll be good to give us a snapshot of how the system's working and not working for different people. Brief individual episodes of treatment are not generally sufficient, are they, to achieve recovery from an eating disorder? People with eating disorders need to be able to step up and down through an integrated continuum of services, and they need to experience their care as coherent and as connected. And these episodes of treatment need to work together to support a kind of incremental change that happens in the person. Isolated episodes of treatment without coherence undermine outcome and the confidence of the person in their recovery, and that isn't what we want. Yeah. Okay, so to the mashup. Still with me? So here's some people, and they're needing something from the system, yeah? What do they need? So we're going to go across and sort of say, pulling together the information from the different ones, what's needed. So prevention, public health information, and advocacy is needed. Do you remember when I said about the system of care that it's not prescriptive as to exactly where these things need to happen, because these things need to happen as a result of local solutions as well, that people find where these functions need to happen in different places. But I've just made it, for the purpose of making it real, I've made suggestions. So, for example, public health information and advocacy can happen through community health services and lived experience organisations who already make a massive contribution in this area. Okay, the next function we need is early identification and referral, yeah? So screening, support to engage with treatment and referral. Where does that happen? GPs, primary care professionals, schools, emergency departments, triage, online programs, yeah? The next stripe of treatment that we need or opportunity is assessment and shared care treatment. So by shared care treatment, what we mean is professionals who are involved in the care team, like a GP who's medically monitoring, those kinds of things, who aren't necessarily the mental health professional doing the exact treatment. So shared care is used in that way. So GPs, private mental health, dietetic practitioners, headspaces, community health teams, and online guided self-help are all in this kind of space. Next, we have community-based treatment, which is individual therapy delivered in community or general outpatient settings, hopefully with a coordinated access to a range of other treatments like nutritional therapy, medical care, well, definitely medical care, and exercise physiology, for example. And this is kind of, in some ways, the engine room of change, isn't it? These regular sessions of evidence-based treatment in the community. So who does those? Sometimes CAMS and AMS do, as in child and adolescent mental health services. Less often adult mental health services get involved in this space. Community-based eating disorders, and obviously private practitioners have an enormous amount to do in this space. Next up, we've got community-based intensive treatment, so intensive outpatient support for people who require more clinical support, more frequent than what you might get by your 1 hour with a clinician each week. This one's very real for me because I see a lot of people who have eating disorders, severe eating disorders, and often, we're on that thing between is this weekly thing enough to hold you and to help you move on, or if it isn't, what's the next we can get? And you have to be so creative around it. It's typical. So what have I said here? So day programs, obviously, and peer coaching is increasingly a new element in the system that can help with intensity. Next one is inpatient treatment, medical, psychiatric, and eating disorder specific. So there are 3 different kinds of categories there. Where does that happen? So medical wards, psychiatric wards, and then in a different category, eating disorder specific inpatient units and eating disorder residential programs are the kind of places. Yep. Recovery support. So I didn't really get this category for a long time, but it was always really strong in people with lived experience saying, this is really important. And I think I get it now after all these years. I get that eating disorders don't just finish after you've been through your steps of care. They so often need something else. And so I think this is really important to keep in mind because otherwise we don't finish treatment and we sort of let people go too early. So recovery support is, where's that happening? I mean, I think it can happen anywhere in the system, actually, wherever the person needs to go, but also in community mental health and dietetic services. Private practitioners, again, play an enormous role. Also online resources and support groups and things like that. So I've put the functions now. This is sort of the context, the infrastructure that we want and suggestions of where it can go. This is the things that we need to have happen, although it doesn't have prevention, which I kind of feel like it needs. And then also crucial to our system of care are the principles and standards that inform it. So they go through everything. And then research. So research and evaluation and ongoing quality improvement also informs the entire thing all the time. And then step care system for eating disorders. So that's our way of expressing it in the best way that we can at the moment, to integrate the kinds of things that we need. Okay, and next. Thought this would happen. Slide 15, yes. Okay, so in summary, an integrated response to eating disorders that fits with that system of care is characterised by that range of treatment and support options which are delivered in varying intensities and lengths to meet the individual's needs. It also is characterised by multidisciplinary treatment. It's not provided by just 1 or 2 sets of people. We need to have opportunities as fit. We don't always have to have every professional involved at every point in the line. I think that's really important to think about. It's about what's the fit for the person and what's the necessary set of people at the different times. And we need coordinated episodes of treatment with planned and supported transition. I'm going to talk a little bit more about what that means in a minute. Okay, so how do we build the system of care? Well, my first answer to that is that I don't need to answer it because we have the wonderful opportunity today to hear from a group of people who are expert systems care builders, and they've been doing that work in Australia for a very long time. My second answer to the question is that Maddie's story is part of that answer. How do we build the system of care is that we are attentive and active at every level of what is happening for any given individual, and we move between those levels intelligently and carefully to build the system of care in that way. And another answer to me is that we build the system of care, we all build a system of care in a sense, because it goes right from the policy making at the very top to me going, oh God, have I got time to make the phone call to the dietitian? I don't know. Haven't met her, I don't know who she is. Shall I? And the answer has to be yes, because if I do make the phone call to the dietitian, I create the relationship with the dietitian that creates more in the system of care. Do you see what I'm saying? It happens in the moments of life and in the very strong sort of policy decisions that we make, I think. The other thing I wanted to leave you with is a very, very useful question that I've found over the years to ask. If you're in a situation where you need to change part of the system, whether it's local, really local, or whether it's, the state of Tasmania or whatever, it can be at different levels, to ask, who is responsible for the system of care? It's just a really interesting question to ask. Who is responsible for the system of care? So, for example, if I asked that question when I was working with the Australian Ballet School around reducing risk and getting early intervention in that particular context, who is responsible for the system of care is a very different answer than it would be for the state of Tasmania. Do you see what I mean? But asking ourselves who has the decision-making power in a given system of care, who cares about it, so who's there with energy in order to help change it, is just really important, because otherwise we can put a lot of energy into trying to change different things, but we never kind of get it to that strategic place where it'll make a sustainable change. Does that make sense? Yeah. So who is responsible for the system of care? The last thing I wanted to leave you with was just some thoughts on what is happening in our system of care at the moment. So I think what we're seeing is an expansion in primary care and community health, that core business is coming into primary health and community care, and the challenges around that are engagement and training and really clear referral and pathways from that sector into the next sectors, because primary care workers aren't going to be wanting to identify eating disorders and to get that early intervention if it isn't obvious to them where to go next. So there's a lot of work to be done there. What's happening in the middle in that core client-centred, evidence-based, community-based treatment? We have had a problem in the past, and to a degree we still do, with there being insufficient provision, just insufficient numbers of context for basic, high-level, evidence-based community care. Our hope is, of course, that the new Medicare items will increase that kind of availability, but that also provides us with some challenges. So one of the things there is the axis between access and quality, and this is always going to be something that's important as we think about the system of care in eating disorders. We want to increase access, and we also need that care to be really high quality and evidence-based. So this is something that we have to work with and think about in that respect. In that middle sort of community treatment part too, the role of public health is something that is at issue and is quite different across Australia. So CAM services, or child and adolescent mental health services, have made a stronger response, certainly in some parts of Australia, than adult mental health services at this point. And this is something, it's going to need to change and become specific. There is still some stigma and some resistance to treating eating disorders in adult mental health services, and this is part of our challenge, because, as I said before, we need to use the whole system to the benefit of people with eating disorders. Taxpayers, money, and all that. And so clarifying and engaging with the public health system and the quality of practice there is really important too. And of course, there's an increase in infrastructure now for inpatient options, and I know that's not everywhere, but to do with the new residential services that are being unrolled in the different states, and also in some places we have enough eating disorder beds. In other places, they're still struggling to get enough. But one of the challenges there is how are those services integrated with, and how do they support the rest of the system? And there are gaps everywhere, gaps in the system all over the place. So just to reiterate that point, I think that as our field in some ways grows, sadly, that it grows, that there's this need for expansion, but expansion that's very much supported by coordinated and communicating across the new expanded areas, and a very strong sort of intention and commitment around continuous improvement and quality aspects across the system too. And just A couple of other really general challenges. I think that we need to increase our cultural and linguistic competence. So we remain a very limited cultural and linguistic group, and we need to be able to be more able to engage with all of the people who suffer this issue, not just a subgroup of them. And we also need to reduce the disparities in access and utilisation and outcomes for rural and regional and states and territories who just aren't properly serviced at this point, and people who can't pay. So today, what we're going to do is we're going to hear from people with lived experience. So we're going to listen and we're going to hear what they have to say about their pathways through care. And then we're going to hear from a group of people who understand building systems, not only at the intellectual level, but at the gut level, I've done this for 20 years level. And then we're going to gather and we're going to hear about peer group work, which is a new element in the system. And then we're going to hear from you. So we're going to choose groups and we're going to actually think about what are the most important things to you to build or change in the system. So I guess I'm inviting you to have that in the back of your mind while you're listening to the other things through the next little while, asking yourself, what matters most to me? It might be something small, it might be something huge. Remember those different levels of care? It might be something here, it might be something here. But what matters to you the most that changes in the next 5 to 10 years? And also, what is most important for the system of care to grow, which is a slightly different question. So we'll come to that towards the end of the day. So have we got another slide or is that it? Oh, I had references. And morning tea. Okay, thank you very much for your attention. I appreciate it.